Okay, so let's move on to part 2 of our program, which will cover care during treatment. I'd like to introduce our 2 panelists, PAs Samantha Salvatora and Alexa Probst. Samantha Salvatora is a physician assistant in the leukemia department at MD Anderson Cancer Center. Her role as a PA focuses on diagnosing and treating acute and chronic leukemias and developing a treatment plans for patients. PA Salvatora is a founding member and leader in the Leukemia Patient Education Program, or LEAP, at MD Anderson, which is a program designed for patients with acute leukemias. She is also active in training other physician assistants and fellows, as well as medical oncology fellows. Alexa Probst is a physician assistant and supervisor of the advanced practice providers in the leukemia department at MD Anderson Cancer Center. PA Probst has developed materials and educational sessions for leukemia patients and family members. She was nominated for Excellence in Advanced Clinical Practice and Outstanding Patient Educator, MD Anderson. Thank you so much for being here with us today. We really appreciate it.
Thanks for having us. Thank you.
So you can go ahead and share your screen.
Oh, sorry. All right, is it showing now? You can see it?
You're good to go.
Okay, perfect. So like Carrot said, I'm Alexa, this is Sammy. We're 2 of the PAs in the leukemia department. So we're going to talk to you just a little bit about treatment expectations, potential complications, and then some supportive care during treatment. Now, I know you guys just heard a lot about AML, so none of this is new, but just to give you a really brief recap. So AML, something that's important to keep in mind, all of us have blasts in our bone marrow. So blasts are just immature cells. All of us have less than 5% blasts in our bone marrow. When you have an acute leukemia, those blasts stay as immature cells and they don't go on to mature, healthy white blood cells, red blood cells, and platelets. And all of this production and then most of the maturation process happens in the bone marrow.
So I get this question a lot. I think both of us do. So why do I need a bone marrow biopsy? We need a bone marrow biopsy because, like Alexa said, those immature blast cells are actually produced in our bone marrow. We all have good blasts. But of course, we see that when we do have an abnormality in our blood cell count, we will require a bone marrow biopsy to see if those immature blasts are those abnormal acute myeloid leukemia or other possible leukemic cells. So the bone marrow is where our little baby cells are actually produced and start to mature until they are then pushed out into circulation. So the bone marrow is required to access that very beginning stage to see what is truly going on at the smallest level, deep down. So what is a bone marrow biopsy? I'm sure some of you, I think, have already experienced this, but in case you have not or are a caregiver and would like to know more, a bone marrow biopsy is typically done when the patient is awake and normally tolerates it pretty well. We use the posterior iliac crest or the hip bone. So what we will do is we numb the surface of the skin all the way down to that bone. Once that area is nice and numb, then a different needle will be placed in through the skin to the bone for us to then be able to access the marrow space where the bone marrow is able to then be withdrawn. During that process, I would say typically patients will tell me, Sammy, that lidocaine is the worst part of the procedure. And then the rest of the procedure is really a lot of deep, achy pressure once we get into the marrow space and then withdraw the fluid. So the marrow fluid itself is like a very thick blood, and then that is sent out for our pathologists to evaluate. And then we will go ahead and do the biopsy, which is like a little chip of the bone, which is normally a lot of achy pressure. And this helps to really ensure that we have adequate samples and are able to give a good sample for the pathologists to evaluate the disease. So how often will I need a bone marrow? The most important time, of course, is right at diagnosis. But unfortunately, this will happen a few times throughout the first cycle of chemotherapy in some cases. So that can happen on days 14, day 21, day 28. So unfortunately, it can happen very frequently. And this is important to evaluate the disease status and then the response to treatment until we can confirm that the bone marrow is in a remission and there is no evidence of leukemia. This usually happens about every 3 months to then monitor disease, because we know we will usually see changes in the bone marrow before we can see evidence of like disease progression in the blood.
So how and where will I receive my treatment? So this varies a lot depending on what kind of treatment regimen you're getting or your family member is getting. Most of the time, that first cycle of treatment is called induction. And usually induction, there'll be some kind of hospital inpatient stay just for closer monitoring. At MD Anderson, for our older patients, we put these patients in the hospital for the entire first cycle, induction cycle of treatment, just to monitor for side effects, try to prevent infections. And then sometimes subsequent cycles can be given outpatient. So if it's an infusion, you may have to go to like the ambulatory treatment center at MD Anderson, outpatient center, come several times a week for the beginning of the cycle. And then there's some treatments now that are oral, so just pills that you would take. So you may have to come to pick up the medications, but then can take them at home. And so depending on your treatment, it may be some combination of inpatient and outpatient, or just one or the other. So what happens during treatment? So typically treatment is given for multiple consecutive days. And then one cycle is about a 1 month or 28-day period, kind of give or take, depending on the regimen and how quickly the counts recover. So during this time, the chemotherapy is targeting those blasts that we talked about in the bone marrow, all of the rapidly proliferating cells. But unfortunately, it doesn't just kill the leukemia cells, but often kills, some of the good, healthy, mature cells. So that's why we see that blood counts, all of your blood counts drop during treatment. And so we're trying to kill the leukemia cells, but we'll also see the white count, your red count, your platelets, all of those counts will drop during treatment. And this is the time when there's the need for transfusions and then the risk of infections. So we call this the roller coaster effect. So you can see, this is a graph of what your counts will do during a cycle of treatment. So around the beginning of the cycle, your counts are a little bit higher. And this is especially true once you're in remission. So for the first cycle of treatment, the counts may start low because there's active leukemia in the marrow. But typically the counts will be higher on day 1. And all the counts will drop: white count, red count, hemoglobin, your platelets. Around day 15 is when everything is going to be at its lowest. So this is the greatest risk of infection. This is when you may be needing the most transfusions. And then what we hope is that the counts recover around day 28, and also we start seeing more good, healthy, mature cells in the peripheral blood.
So during this time, when we get chemotherapy and that period after where we no longer receive chemotherapy, it's really important for our blood counts to be monitored very closely. So here at MD Anderson, we have this fast track clinic, but I know outside patients will see their local oncologists for blood checks. So we would recommend checking blood about 2 to 3 times a week for these patients with AML. And that is to really monitor to see if there is a need for transfusion. I think that's number 1 on our list. We also check for electrolyte replacement. So we can have electrolyte abnormalities, and monitoring for side effects from that chemotherapy. And then the other most important thing during this time period where we're checking blood counts is also to be helping to manage any side effects that patients might be experiencing from the treatment. And most importantly is really monitoring for any sign of infection, because we get very concerned about infections in our patients with AML. So why is it important to monitor our blood counts, or what are we looking at when we monitor someone's blood counts? The first thing is our white blood cells. Our WBCs is really an umbrella term for a bunch of different types of white blood cells. The most important one that we always really focus on is our neutrophils, or we'll sometimes refer to as our ANC, or absolute neutrophil count. And these are our good white cells that help our body fight off infection.
And Sammy, what is like that ANC? What is that number when it's below that patients are at an increased risk of infection?
Great question. So the big number that we are looking for is a neutrophil count of 1.0. And when that count is less than 1, which we see a lot in our patients with AML, we're at a very high risk of infection, because the body doesn't have enough white blood cells, those good white cells, to fight off any foreign bacteria, viral, or fungus that might it acquire or run into. The other thing we look at is our red blood cells. The main thing we always focus on is our hemoglobin. The hemoglobin is important because it is what helps oxygenate all of our cells in our body. So when that drops, we sometimes then require transfusions. And the last one is our platelets. Platelets are important because they help with clotting. So if you get a typical cut or help to prevent any type of nosebleed, they are very important. So this goes into blood transfusions. We will, if patients' hemoglobin drops below a certain level, for us, that magic number is usually less than 8. Or if the patient is symptomatic, we will transfuse packed red blood cells. And I do also like to point out that it sometimes does take a few hours, or sometimes even up to 24 hours, for a patient to really feel better after this transfusion. And then these transfusions do take a while. So one bag of red blood cells takes about 2 hours to be transfused. So it is a timely process. And then platelets, we will transfuse typically if that platelet count is less than 20. And that's to really help prevent any risk of spontaneous bleeding, or to help if there is active bleeding, like a patient's having a nosebleed or has a cut or something that just won't stop. And that takes about 60 minutes to transfuse, so about an hour for platelet transfusions. Then rarely, but it can happen, we can actually transfuse white blood cells, but we don't do this because there's like a certain number threshold. We only transfuse white blood cells in rare circumstances when there is an active infection. And this requires a family member, someone who is like kind of matched perfectly, to then donate for a specific patient.
So like Sammy said, we consider neutropenia when that neutrophil count is less than 1. So when the neutrophil count is less than 1, this is the time that you're at an increased risk of infection. So you may see that the counts are high at the beginning, but for maybe a week or 2 in the middle is when that ANC is going to be low. When your neutrophil count is low, your immune system just isn't competent. So you won't have kind of the same immune response to an infection that you would if you were healthy. So if you had a pneumonia, you may not develop a typical cough like you would otherwise. So a lot of times the first and sometimes only sign of an infection is fever. And that's why we take it very seriously at MD Anderson. So any fevers, 100.4 or higher, that's a direct trip to the emergency center. And studies have shown that the best outcomes happen when antibiotics are administered as early and as quickly as possible. And so that's why we just don't mess around if there's any potential infection directly to the ER, so we can get antibiotics and treatment on board quickly. So these are neutropenic precautions. A lot of these are common sense. At MD Anderson, anytime the neutrophil count is less than 1, we want all of our patients to be on an antibiotic, an antifungal, and an antiviral medication. So washing hands, monitoring temperature like we talked about. This also involves not taking medications that could potentially lower your temperature so that that might mask a fever, avoiding people who are sick, crowds, and then just being kind of careful about what you eat. Some patients will prefer not to eat out during this time just because they're not preparing the food themselves and making sure that it's washed and cooked correctly. And then when should I go to the ER? So fever, like we talked about, sometimes accompanying fever or even on its own, and patients will have chills. So sometimes really those very, almost violent shaking chills. So that can be a sign of infection. Confusion or altered mental status. This could indicate an infection, but also when the platelet count is low, and that puts you at a risk for bleeding, and that could be a nosebleed, that could be bleeding from the gums, but it also could be a bleed in the brain. And so any new onset, severe headaches, any confusion, that is a direct, immediate trip to the ER. A fall, because you're at risk for infection, platelets are low, that can result in some serious injuries. Any pain, any bleeding, inability to eat or drink, you're can get dehydrated quickly, blood pressure can get low, puts you at risk for falls. So, we want you to come straight into the ER. And kind of our general rule of thumb is that if you're trying to get in touch with your care team because you have an urgent issue and you need to talk to them immediately, that probably means that whatever you're calling about requires, urgent evaluation in the ER. So just kind of a rule of thumb to just go straight there.
Yep, that's a good one. All right, so common side effects from chemotherapy. There are a lot of different types of chemotherapy, immunotherapy that you, I'm sure, have been listening and hearing about. But in general, we see some of the same repeating symptoms and side effects from chemotherapy. So we just thought we would touch base on some of them. And our bottom line, we're here to try to help treat these side effects and make chemotherapy as easy as we possibly can. So one of the most common things that we will hear is mouth sores, or we call it mucositis. And that's because, like Alexa was saying, with chemotherapy, it is targeting our good cells and our bad cells. So it's also kind of just wiping out the entire lining in our mouth all the way through. So one way we know to help prevent these mouth sores is a mouth rinse. Very simple. It is just salt and baking soda and water, and you can swish and spit a few times a day. That really seems to help. And then we do, of course, have prescription medications, mouthwashes, if that does not, or if you do get a mouth sore. Another thing we'll hear is lack of taste, or kind of like a metallic-y taste with all foods. So we found that lemon and citrus items really do help, like a lemon wedge or the lemon head candy. That helps kind of with that metallic-y taste. And then also you can talk to your doctor about doing like a little zinc supplement, also helps improve that loss of taste. Two that we commonly see kind of go back and forth, unfortunately, is diarrhea and constipation. With constipation, we recommend a lot staying hydrated. You'll probably feel better too if you stay nice and hydrated. That'll help keep the bowels moving. Try to stay active as much as possible. And then for the most part, it's okay to use over-the-counter stool softeners. For diarrhea, the big red flag is if there's more than 6 episodes of diarrhea in a day, we want you to go to the emergency room, because that could be a sign of infection. And then you can also be severely dehydrated and have electrolyte abnormalities. So that would be a red flag to go to the emergency room. Otherwise, it's occasionally okay to use like Imodium. For nausea and or vomiting, I think for the most part, we've done a pretty good job trying to prevent this with chemotherapy, because a lot of our patients will get pre-medded with these. But we do recommend just having on hand from your provider, like Zofran or Compazine, something to help with nausea, to, of course, allow you to eat and feel better. And some patients too have just found supplements like ginger or ginger chews really also are another nice way to help prevent that nausea or help treat it. There's of course a lot more other possible side effects, but our bottom line is, we're here, we're your team, your providers want to hear from you. I know I have patients that are like, oh, I don't want to bother you, but I'm like, I want to hear what's going on. We want to try to help prevent and make you feel as good as you possibly can during this time. So beware of side effects, and of course, please discuss with your provider. And I think that is kind of all we have, and we would love to answer any questions that you all have.
Okay, thank you guys so much. That was great information to have. I have a couple of questions that I wanted to ask you guys that I was curious about. One is, a lot of patients struggle with the lack of appetite. And is there things you can suggest on how people can, what things people can eat or things people can do to make sure that they're getting enough calories? Or are there certain things that might be easier to eat than others when they're going through chemotherapy?
Yeah, I think I have found a lot of the lack of appetite sometimes is also related to underlying nausea. So I will recommend my patients to try taking an anti-nausea medication like 30 minutes prior to either taking their medications or before they try to eat, to see if that improves appetite. Sometimes it works wonderfully. Other times it's just trying a very bland diet, soups, broths, nothing that's like overwhelming with flavor or like smell, because that can also trigger nausea. And then of course, we always encourage our patients to try to have a lot of liquids too. And one of those good sources would be through like your Boost, your Ensure, or Gain, any type of like liquid supplements. Do you have anything else?
Yeah, the only other thing, I know sometimes it's hard for people to feel like they want to sit down and eat like one big meal. And so some patients find that just eating very small but more frequent meals is easier to do. And then I just recommend kind of trying to get the most bang for your buck. So if you're going to sit down and eat, don't just eat a few crackers, but try to have peanut butter or cheese or things that have protein. So kind of getting the most calories in the smallest quantity of food.
Calorically dense items, or I'll even tell patients if they really like milkshakes.
Totally.
I'm like, have a milkshake and add a scoop of protein powder. Or if they don't like the Boost, like mix it in with a smoothie. So I think also smoothies are a great option too for patients, because you can make those really dense and they seem to be easier to kind of eat because it's not as hard.
Okay.
I know there's like supplements too that I'm not a huge fan of the like appetite stimulants. So they just also have a lot of side effects. And I know our patients, I think the last thing they want to do is add another medication.
Okay. Yeah, it sounds like keeping the nausea down is kind of the first step too.
For sure.
Yeah.
That will help with the appetite. One question from a patient: is a neutropenic diet necessary after transplant?
I can't say 100% with transplants. So both of us work in leukemia. I will say for our acute leukemia patients, I know the studies have shown that there is not a difference between like washing your vegetables, fruits and vegetables very well versus eating like raw, or not raw, but like very, very cooked vegetables. So I think that whole neutropenic diet, I think we can be a little more lax on it. But I think the bottom line is if the patient is neutropenic and that ANC has been less than 1, I would kind of stick to that neutropenic diet, just making sure everything is washed well and cooked well.
Yeah, I think that's whether you're post-transplant, pre-transplant, in remission, but just being aware that anytime that neutrophil count is less than 1, you just don't have the same defenses that you do otherwise. And so that infection can come from anywhere, including food.
Okay. Okay, and we have another question. Thank you for that information. We have another question from a patient who's asking about exercise and your thoughts on exercise. And he's asking specifically between inpatient and when you're outpatient. If you have any thoughts on that.
I love when patients want to exercise. I'm like, keep on moving. So I think exercise, whether it's walking, if a patient's always a jogger, I always say keep your normal exercise routine as normal as you can. Of course, if you weren't a runner and are like, well, I have leukemia now and I'm going to run a marathon, that's probably not like realistic. But if you're someone who's always just been a big exercise person, enjoys cardio, I tell my patients, listen to your body, exercise, but don't push yourself too much. And then I think our only thing I really tell them not to do is a lot of strength training, because a lot of times patients have like a PIC line or a central line, and lifting, I think more than they say 5 pounds is not recommended because it could dislodge the line. But I tell them it's fine to do like lower body exercises. I encourage patients to be as active as their body will let them, because it helps too in the long run.
And I think keeping in mind that, when your hemoglobin is low, you're going to feel more tired. So kind of like Sammy's saying, listening to your body. Kind of the only concern is when your platelets are low. So then you're just at risk for injury, bleeding. So then we kind of want you to take it easy. But, a walk around the block or something like that is fine. So, listening to your body, and then also trying to avoid more dangerous activities when your counts are really low.
Right. Yeah, I did have a patient, someone who is like a road biker, better to do something stationary just because we're at the risk of falling. And like Alexa was saying, with the platelets being low too, whenever they're in that kind of that nadir period of treatment, we also don't want the blood pressure going up too high, or your, heart rate to go up too high. So again, listen to the body and just kind of easier exercise. But I definitely have patients that have exercised all through treatment, and it helps keep them going.
Okay. That's great advice. And I know that AML is very emotionally challenging, and you have to think about patients' mental health as well. And one patient is asking, are there any specific recommendations about getting psychotherapy to handle the change, or about social engagement levels? Is there anything that you've seen that is particularly helpful for patients on the emotional, mental level?
Yeah, I think AML is so tricky, right? Because not only are you dealing with the mental health of now you have leukemia and you're going through treatment, but also you have to be really careful about not being around a lot of people and this risk for infection. So then it also can feel isolating. So it's tricky. And I think, of course, the people who have that good support system, I think leaning into that, really tapping into your support system as much as you can, talking with a social worker. I mean, they're available at MD Anderson, they're available at other facilities. So really, speaking up if you're struggling, and utilizing the resources that are available, whether it's counseling, it's support groups, it's medication if needed. So I think just kind of having that conversation with your healthcare team, and yeah, and really trying to lean on your support system as much as you can.
Yeah, I agree with Alexa. I think therapy and just finding someone to talk to, even if that is a professional, because I think it does help to for patients and even for family members and caregivers, just to have that outlet. And I think it's become a lot easier too to find, I think, a therapist or like a licensed counselor nowadays. And there's even like apps online. There's a lot too, because patients will have like, or family members with like, will talk to me about having just anxiety or being stressed. And there are a lot of apps to utilize, and then like meditation apps. We also at MD Anderson, I really like the supportive care team because I think they have really great counselors, and they're able to talk to patients and figure out what might be the most beneficial. And then of course, like the Leukemia Lymphoma Society, and I think support groups like Alexa said. And like with friends and family, I find the support system being really beneficial. So I tell patients, I don't want them to like live in a bubble. I want them to be around people. So I know it's been really difficult too with COVID, but if they're able to do things outside and in a safe distance, I think that really helps to get them through the tough times.
And is that something that they should that their doctor should say, that their doctor is telling them less, like, yes, you can go, around people at this point, or you should really be careful at this point?
And a lot of it depends. That ANC is like a magical number. So when that ANC is less than 1, that's when we're going to tell you that you need to be really careful about who you're around, really kind of a little bit isolating a little bit more. When your ANC is above 1, so at the end of treatment, before you start your next cycle, that's a really great time. Like I have a patient who that's when she goes to see her grandkids, is during that, that week or 10 days when her counts are high enough. So just, maybe waiting on some of those activities till that neutrophil count is above 1.
Yeah. Always reach out, talk to your provider, your PA, your nurse, your physician. We're happy. I would like so much rather get questions from patients than, and like, I don't know, to help improve the quality of life. Like my bottom line when I talk to my patients, I want to do whatever I can to keep my patients safe, but then still allow them to have a life outside of everything. So talk to your provider. I know patients are always like, I don't want to waste your time. You're not wasting my time. Like I'm here for you. So we just want to make God as much as possible.
That's why you do what you do.
Yeah.
Well, and you brought up a great point about the apps. I think some people are comfortable talking to people. Other people, prefer to kind of be on, maybe they're a little more introverted. And I think the apps today, there's so many, and there's a lot of great apps out there that address mindfulness and sort of staying in the moment. And I think that's important with AML, and sort of, not trying to, you can't get too far ahead of yourself into the future.
One day at a time.
One day at a time.
Yeah, for sure.
So, well, this has been great information, and we just thank you guys so much for taking time out on a Saturday, and we thank you for all you do for the AML patients.